Good evening and welcome everyone. I'd just like to begin by acknowledging that the traditional caretakers and custodians of the lands on which we all meet tonight. I'm on Wiradjuri country and pay respect to all elders past, present and emerging, and recognise a continuing connection to land, water, culture and community. I extend that respect and warmly welcome all Aboriginal and Torres Strait Islander Australians who are present tonight. Thank you for joining us, everyone. Just a little bit of housekeeping. If everyone could just type your full name into the chat box, and that way Erica, Katie and team can record your attendance at tonight's event. In terms of questions, Raj and Kath would really like that if you can use your raise hand function. So if you go to the reactions icon on the toolbar, you'll then be able to click on the raise hand function and we'll see that you're there waiting to ask a question. Alternatively, if you'd rather type a question into the chat area, that is also fine, and I can then transmit that question to Raj and Kath. Okay, and just to let you know that this session will be recorded tonight for the purposes of people who aren't able to make it tonight but would like to learn the same information. Okay, so tonight's presenters, I'm really pleased to be able to welcome Dr. Rajat Rai, medical oncologist. So Raj is working at Double Base Hospital. He's has a keen interest in immunotherapy and cancers related to immunotherapy treatment. So that includes lung, melanoma, renal and upper GI cancers. Raj did his training in medical oncology in Canberra and has a fellowship in advanced melanoma from the Melanoma Institute in Australia. We also have Kath Osborne with us tonight, and Kath is Deputy Chief Radiation Therapist at the relatively newly open Western Cancer Centre. Kath has over 30 years experience in RadOnc, specifically radiation therapy in RadOnc, in a variety of clinical leadership, research, education and academic roles. Kath completed a Bachelor of Radiation Sciences, Radiation Therapy and Master Health Sciences at Sydney Uni, as a graduate diploma in healthcare management at Western Australia's Institute of Management. And she also has a PhD from Monash University. Kath is passionate about rural health, health professional education, and ensuring humanity and compassion are part of both the patient journey and our health professional experiences. So thank you very much to both of you, and I'll hand over to Raj.
Well, thank you, Dr. Chua, and thank you, Erica, for giving me this opportunity to present something that I really like. Now, I'll just start with the learning outcomes, which is basically identify the various cancers where immunotherapy is used and associated mechanisms of action. Very important, how to recognize immune-related adverse effects, and also how we formulate the plan. So with that, I will start. Can you guys see my slide? Hopefully, yes. All right, so this beautiful place that you can see on the background is our Western Cancer Center in Dubbo. And I work here. I've got the privilege of working here. So we're going to talk about immunotherapy. So basically, before I start about immunotherapy, I'll just give you a brief understanding of why and how immunotherapy came into being. So the concept of immunotherapy is based on the fact that we think that every one of us has got cancer cells in us, and that's due to the error in transcription. But our immune system should be able to do an immunosurveillance and eliminate them. There are various pathways through which this happens. And when there is an error in pathway, that's when the cancer develops. It first reaches a phase of what's called equilibrium. And then when it grows beyond, that's when you get overt signs of cancer. That is also evidenced by a theory which is called a Yin-Yang mechanism of immune escape. Here you can see there's a seesaw kind of a thing where you've got immunosurveillance on one side and then immune escape on other side. And there are various factors that are mentioned underneath that play a role in doing that. Now, this is not new because this was observed in 1800s by Dr. William Cooley, who actually noticed that patients of his who had head and neck cancer, who started developing some infection in those ulcerated lesions, actually started to respond by themselves. And there was a startling discovery that was made at that time, and that he started doing injections of streptococci or erysipelas into the cancer. And you can see a couple of photos which showed that it had started working, but it was not picked up that well initially. And as we went on with more understanding, we saw that there were other modalities that came into being, including BCG, which is a vaccine for tuberculosis, which was instilled in the bladder, and it worked by immunogenic mechanisms to cure. And it is still being used as a very effective way of actually treating bladder cancers. In fact, it is considered to be the last resort, first and the last resort for treating non-muscle invasive bladder cancers by immune mechanisms. However, it was in late 1990s when the concept of immunotherapy as checkpoint inhibitors came into being, and they eventually got approved in year 2011. In between, we had interleukins as well that was being used. The original cancer that brought all of this thing into the foray was melanoma, which was initially considered to be a graveyard of drug development, where every new chemotherapy that was attempted did not work. And it was with the effort of these two guys who were eventually given Nobel Prize recently that immunotherapy actually came into clinical practice, Dr. James Allison and Dr. Honjo. Dr. James Allison was attributed to the discovery and use of CTLA-4 inhibitor, which is more commonly or most commonly known as ipilimumab. And Dr. James Honjo was the one who brought the PD-1 inhibition pathway into clinical practice. Since 2011, when we only had ipilimumab that was available, to 2022, this is what the scene looks like. So we've got 2 anti-CTLA-4 inhibitors, 2 anti-PD-1 inhibitors, and multitude of anti-PD-L1 inhibitors that you can see that I've named there. They are used as single agent, they're used as combination of these drugs, or they're used in combination with chemotherapy or targeted tablets. Or the more newer things that are coming out is that there are multiple mechanisms, there are multiple pathways which these drugs are being actually combined and used together to improve the outcomes for cancer patients. How do these drugs actually work? So in a very, very simplified way, I'll just try and explain where CTLA works and where PD-L1 works. So CTLA drugs are basically in the peripheral lymphoid tissue. That is where normally when you get a cancer cell which is surveyed just like an infection by our antigen presenting cell, then that antigen presenting cell then goes to the lymphoid tissue and leads to proliferation of lymphoid cells, T cells, to try and go back and kill that cancer. For that activation to happen, it requires 2 pathways to remain active so that it can continue to proliferate. However, the antigen presenting cell from this cancer very carefully and smartly masks and blocks the CTLA and therefore the T cells do not recognize this as cancer cell and recognize this as their own cell and then go to sleep. The CTLA blocker is the one that actually blocks that CTLA pathway, thereby releasing the brake of the inhibition and leading to T cell proliferation, which then goes into the system and controls the cancer. Now, this happens in the peripheral system. There is a slightly different mechanism that happens in the tumor microenvironment, i.e., exactly where the cancer cells are. So even when, let's say, for argument's sake, the T cells are recruited in the tumor, the cancer cell, again, very smartly inhibits it by producing a veil with PDL1 and PDL2 ligands, which goes and blocks the PDL1. Therefore, the CTLA then recognizes this cancer cell as a normal cell, and the cancer cell can continue to proliferate. That is where this PDL1 and PD1 mechanisms go and block these receptors and ligands, thereby leading to T cell proliferation in the tumor microenvironment, leading to control of cancer. Now, this mechanism initially started with, as I said, melanoma, but as you can now see, the list that I've produced here has got almost all the cancers that are there. They are now, every couple of months, a new indication is getting approved by FDA, later by TGA, and then later on by PBAC. So most of these drugs, most of these cancers are now being managed with immunotherapy. And if you can't find a cancer there on the list, then we've got clinical trials available so that we can put those patients on a clinical trial with immunotherapy. Now, these treatments have actually become mainstay of treatment for a reason. And I've just taken this photo of the page from NEJM, which is one of the most reputed journals. And this study was actually presented at ASCO this year. And after that, we have had so many patients actually come up and ask us about this drug, that they wanted this drug. Now, in this drug was used on 18 cancer patients who had rectal cancer, right? And they did not undergo radiation, chemotherapy, or any surgery, but they had this PDL1 drug. And you can see from baseline how the endoscopy, how bad and ugly the cancer looked, what the pathology was, what the MRI was, and what the PET scan was. You can see how active that disease was. And slowly with time, you could see how the cancer almost got eradicated. So it's called a complete metabolic and a complete pathological response. You can see the histopathology that's there as time goes on. And these patients, there are 18 of these patients who were all enrolled on the trial. 100% of them had complete pathological response. Having said that, that does not always translate into real world. This was a phase 1 study. More studies would be done on them before this drug actually gets approved. But I can tell you about my own experience with one of my very young patients who I might be sharing with one of you guys. This was a young fellow that we had seen about 4.5, 5 years ago, who came in with large lung cancer, which had metastasized to T4 vertebra. This was confirmed on bronchial brushings and immunohistochemistry and next-gen sequencing, which showed a KRAS G12C mutation-driven cancer. Now, this patient was given a combination of a drug called atezolizumab, bevacizumab, carboplatin, and paclitaxel. He had 3 cycles of this drug, had a PET scan, which was performed at Royal Prince Alfred Hospital. You can see it was done in 2018, about 3 cycles after the treatment. Now, this report was reported by Dr. Mark Fulham, who reports PET scans for RPA, and RPA does lots and lots of PET scans for years. Now, you can see the conclusion that he has written. There has been a remarkable response to therapy, the best that I've seen, right? This patient then underwent surgery. The pathologist actually called us and asked us, are you sure you've got the right guy and you've taken out the right areas? We went back and looked at, I mean, we didn't actually believe it, to be honest, and we went back and looked at the previous slides, scans, images. We were right on the money, and this guy had an amazing response to an extent that this is the post-operative histopathology, that there was nothing that could be seen, no cancer could be seen. He's still undergoing treatment with maintenance atezobev, almost like 4.5 years. But unfortunately, all good things come with a price, and the price is absolute new kind of toxicities. Now, we are, as oncologists, chemotherapy is just getting a little bit out of favor, and most of our cancers, as I've shown you, are now being treated with immunotherapy. And at this juncture, it is very important that the primary care physician, who has got most contact with the patient, knows a little bit about it and knows to also identify what to look for if they get any kind of toxicity. Now, I've given some references from where I've made my slides, and I've actually gained my knowledge. You can go there and have a look. But the very important things that I always tell my patients is that any organ or any system in the body can be affected. You really need to have a very, very high index of suspicion. There are no ways in which I can predict what toxicity anyone is going to get. Toxicity can happen at any time in the course of treatment, i.e. within minutes of infusion, or even months after cessation. So like pembrolizumab is now only given for 2 years in most cancers except for melanoma. We've seen patients developing colitis and all those kind of things 6 months after we've completed all the treatment. The other thing is we quickly rule out all the other causes, identify the red flag organs or replaceable organs, and I'll explain you what I mean by that. There's always this question about whether if someone gets an immune-mediated toxicity, i.e. because of the hyperactive immune system, you get some kind of toxicity, does that translate into a good response? There have been surrogate or anecdotal data to say maybe, but it's not always the case. So there is a chart in my room, which I go through with most of my patients. And I tell them that this is not the end all, but these are the most common organs that are generally affected. So as you can see, none of the organ systems is actually spared. You can get various kinds of toxicities depending on the organ that is involved. ESMO has identified 5 pillars of management. I feel this is kind of a jargon, but I'll go through that. So you anticipate that somebody may get toxicity, you try and detect it, exclude, consider it as an IRAE. Then you treat it by, depending on what the grade of the toxicity is, you monitor them for response of the toxicity, carefully monitoring their disease as well during that time. And you give some advice regarding preventing that thing from happening again, which is pretty basic. I'll just skip that slide because this is almost a repetition of what I'd said. Now, do we have some idea about when somebody would get it? So there have been, when immunotherapy was only used in melanoma in a handful of patients, there were certain observations that were made that what would be the usual timelines of when you get toxicity, when you get rash, when you get pruritus, when you get liver toxicity. But as the indications have expanded and we've started using these drugs in almost all the patients, those timelines have now blurred out and have become unreliable. So I really don't rely on just the timelines. I really rely on what the patient is saying and what I feel what's going on. So now we'll just move on to a few cases Now, most of these cases are my own cases that I've experienced over the last 4.5 years while I've worked in Davao, and I've classified them as organ-related toxicity. So I'll give you a few of my patients. Again, I might be sharing it with a few of you guys already. So this is a 60-year-old lady, Mrs. LK, who had a BRAF V600E, who has got a BRAF V600E metastatic melanoma. She initially had presented a couple of years ago, underwent a resection, and it was a stage 3 disease. But she had IgA nephropathy, so we decided to give her dabrafenib and trametinib, which is a BRAF/MEK inhibitor, instead of nivolumab, because nivolumab can predispose to an autoimmune condition, and she already had IgA nephropathy, which may have had made her nephropathy worse. She, with very great difficulty, ended up finishing 1 year of treatment with BRAF/MEK inhibitor, but instead of having those medications every day, we could only get by using BRAF and MEK inhibitor 2 to 3 times in a week with the use of steroids, because she had developed dabrafenib and trametinib related fevers, which is a very common side effect. Unfortunately, 6 months later, she progressed with bone-only disease, i.e. the cancer relapsed only in the bones, which was confirmed on a bone biopsy. Because she had already failed BRAF/MEK inhibitors, we decided to very cautiously give her ipilimumab and nivolumab, worrying about what's going to happen to her kidneys. I had a long discussion with her nephrologist as well, but we then decided to bite the bullet and give that. So she had 2 cycles of combination of ipilimumab, which is a CTLA-4 inhibitor, and nivolumab, and presented to ED. Now, this is a cut and paste from the actual ED documentation. So you can see diarrhea 8 to 9 times, just watery, no blood or mucus. Some over-the-counter antidiarrheal medications were taken without much relief. And then rest of it is blah, blah, blah. So we organized for her to come into the hospital and do the usual stuff,
That's
i.e.
burning. I don't know. I can't do everything.
Sorry? Right, okay. So we do the usual stuff. We did the stool cultures, did the CT abdomen. CT abdomen did not show much, so there was no evidence of colitis that was seen, but there were clinical features of colitis. Now, you can see that I've ordered something called fecal cal or ficus calprotectin, and have also done TB gamma interferon. I would like to know if someone knows why I would have done gamma interferon, if someone has any thought. All right, I will give an answer in a little while as we go along. So what did we do? I was not 100% sure what was going on, so I asked one of my very good colleagues to actually do a flexible sigmoidoscopy on her. And biopsy. So this is what the flexible sigmoidoscopy showed. It showed diffuse mild inflammation from anus to descending colon secondary to left-sided colitis. This was then biopsied, which confirmed that there were fragments which showed acute inflammation with neutrophils in surface epithelium and crypt epithelium, which is kind of very in keeping with immune-mediated colitis. We then decided to give her, so you can see the fecal calprotectin, that was 1300. So what I expect is about 150-ish with anything, but that was very high. So we decided to give her some treatment, and we'll talk about those treatment. So normally, at this point of time, when someone comes in with what we suspect is colitis, we normally would grade their toxicity first, always. So grading is very simple. You can get onto AVQ, or you can go to something called a CTCAE calculator, and you can put in their symptoms there, and it will spit out what grade of toxicity is there. So if you get diarrhea less than 4 times a day 4 times per day, you call it as grade 1. If you get 4 to 6 times and they're not interfering with your activities of daily living, you call it grade 2. Or if you get symptoms of colitis, i.e. abdominal pain, mucus, or blood in the stool, that still makes it grade 3. Anything that's over 7, so she had 8 or 9 and was affecting her ADLs, so that made it grade 3. Now, the next slide is slightly busy slide, but I'll just, so depending on what the grade is, we work out what we are going to do. So this patient had what's called grade 3 colitis. So I actually gave her 1 gram of IV methylprednisolone for 3 days and then started tapering off the prednisolone. The prednisolone tapering is very slow and it takes about 6 weeks. So I start with 75 to 100 milligrams of prednisolone and taper it over the next 4 to 6 weeks while monitoring their symptoms. There are a few patients that you see who are called steroid refractory. So if their diarrhea or their colitis does not improve within next 2 to 3 days, we bump up the treatment. And the treatment management summary is like, if they are symptomatic, we just do symptomatic treatment if they're grade 1. If they're grade 2, i.e. if they're less than around 4 to 6, we just give them oral prednisolone. Or if they've got high-risk features on sigmoidoscopy, colonoscopy, I'll straight away go with methylprednisolone followed by prednisolone. One thing that I've not written here, so if they are refractory, instead of prior to vedolizumab, we give infliximab. Infliximab is given at a 5 milligram per kg dose. And that is the reason why any patient who comes in with colitis, I would always check what their TB quantiferon is because of the risk of latent tuberculosis flare with infliximab. Now, this patient eventually actually needed 2 doses of infliximab because once we started tapering off her steroids, she had rebound colitis. So we had to bring her in to give us another dose of infliximab and then continue with her steroid taper. Unfortunately, with the steroid taper, she developed steroid-induced type diabetes mellitus, which is going to be another problem for her. But her colitis is better. Now we move on to the next case. This is Mr. MD, who is a 65-year-old gentleman who was diagnosed with advanced melanoma. He was actually initially diagnosed as a sarcoma of small bowel. Eventually, after next-gen sequencing, it was confirmed that it was not a sarcoma, but resembled more like advanced melanoma. So he also had a combination of ipilimumab and nivolumab. He had 3 cycles and came in for his pre-cycle 4 review. Was completely asymptomatic, was expecting everything to be hunky-dory. But this is what we saw. So you can see that the ALT and the AST had jumped up all of a sudden from 31 to 157, 52 to 279. So this gentleman had what it looked like colitis. So we didn't go ahead with the treatment that day, and we monitored this guy. So when we started monitoring this guy, you can see we gave him a dose of IV methylprednisolone. He started improving. And as we were tapering, this is what happened. So his ALT, AST started rising again to an extent that you can see on the right side on 6th of May, it was 1091. And I actually met this guy the other day, and he said, I had to actually transfer this guy out to Sydney. He said the ALT and AST had gone up to about 1600s at that time. So he came in and he was commenced on treatment for his hepatitis. We normally we do all the usual things to rule out any autoimmune causes of hepatitis, And if things are looking bad, we end up doing an MRI and a liver biopsy. He had all of those things, and the liver biopsy again was consistent with inflammation rather than anything else. So this guy, we had to commence on mycophenolate, which is one of the second-line agents, on top of steroids. And I had to actually use azathioprine as well in him, but we managed to save and not give him ATG. Unfortunately, while we were actually tapering this guy's steroids and immunosuppressants, his melanoma started progressing. And while we were still tapering him off prednisolone, we actually had to restart his immunotherapy, but just with a single agent. So this is a summary slide for the treatment of hepatitis. This just says the same thing what I've just explained to you, about 4 to 6 weeks of steroid taper is generally needed. But this guy actually ended up needing almost like 3 months of treatment, and he was on PHN prophylaxis as well. The third gentleman, again, another sad story with melanoma, who had a stage 3 scalp melanoma in 2018, was commenced on adjuvant nivolumab, which we give for 12 months. So we can give either pembrolizumab or nivolumab in adjuvant settings for 12 months to reduce the risk of relapse. About 8 months into his treatment, he was at one of the malls in Dubbo, and one of my friends who is a GP actually helped him out because he had a seizure in the mall there. When he came in, he had a CT and an MRI, and the CT showed this big nasty lesion in the sphenoid region, and multiple areas of brain metastasis had developed. We shipped him down to RPA, where he underwent some debridement and then had some radiation to this bed and some stereotactic radiation to the few lesions that he had, and was commenced on dabrafenib trametinib. Unfortunately, while he was on dabrafenib and trametinib, he progressed, was commenced on ipilimumab and nivolumab, which is again a combination immunotherapy, and 3 cycles of ipi-nivo came in with the CT scan, which is on the right side with shortness of breath. This is 2 weeks prior to this scan. He had absolutely pristine looking lungs with no cancer, no nothing anywhere. And within 2 weeks, this is what the scan looked like. Right? And I'll combine another case with this fellow who had a very similar history, but with a different drug. So this was Mr. RL, who was a 70-year-old man who had stage 3B lung cancer. For stage 3B lung cancer, he underwent chemo radiation with and followed by another anti-PD-L1 agent called durvalumab. This is something that we do very commonly. Someone who has got stage 3A or stage 3B lung cancer that we think we can cure but is not up for surgery, we will combine chemotherapy and radiation together. And after they've had 6 weeks of chemotherapy and radiation, they will then undergo 1 year of anti-PD-L1 treatment with durvalumab. Now, 3 months into the treatment, I was just about to take a break for New Year. And this guy, I was actually at Dubbo Airport and organized for him to have, he came in with some cough and a little bit of shortness of breath, which was non-productive. So I organized for him to have an HRCT. His wife called me while I was at the airport, and I had a look at the scans at PRP on my phone, and this is what it looked like. So quite good going area of pneumonitis. Suspicion was raised whether this was secondary to radiation. Radiation can cause pneumonitis, but just the general pattern in which the pneumonitis had occurred, it did not follow the usual lines of straight lines of radiation. It looked like a lot of radiation was there outside. A lot of pneumonitis was there outside the radiation field. So we had to unfortunately abandon the treatment. And while he was having that thing, he having systemic treatment for this pneumonitis, he came in with while walking, which was looking very funny. So he had a bit of tendonitis in his Achilles, and I organized for him to have an MRI of bilateral Achilles. Now you can see all that white thing in his Achilles tendon. So he had severe bilateral mid to proximal Achilles tendinopathy with longitudinal splitting. Right? Now, coming back to his lungs. So again, we grade all the toxicities always to decide how we are actually going to manage these toxicities. So grade 1 is asymptomatic. A lot of times you may only find radiographic change, but if the patient says that they are getting some cough, shortness of breath, I generally get them an HRCT, and that upstages them to grade 2. Now, depending on if there is any hypoxia or any limitation to activities of daily living, we will go ahead and give them steroids. It's basically to dampen the immune system, which is hyperactive and working against them. Or if it's severe, we give them methylprednisolone and then again slowly taper it. If they are refractory, there is some role of mycophenolate and infliximab, but I'll generally get my respiratory colleagues involved in that to work out how best to manage them, because these patients can actually have long-term fibrosis from this pneumonitis. Case number 5. This is a 54-year-old gentleman, Mr. RB, who had stage 3A lung cancer, who was again given the same thing. Now this is a screenshot from my notes. You can see 2019. This man is still alive, doing quite well. Had adjuvant durvalumab, developed a little bit of thyroiditis, came in for a review, but was quite short of breath. More than short of breath, he was actually hyperventilating because he was saturating well. He was just feeling very dry and had a lot of trouble with his urinary symptoms, Fortunately, I had seen one case where I could not pick it up in my training phase. I asked the nurses to very quickly check his blood sugars, and his blood sugars were extremely high. We recently had another case, I think, Catherine, where one of the patients that I'd sent down for PET scan had very similar findings that you could not, the nurse came up and said that the sugars were really very high while she was on immunotherapy. So it was negative on ketones and had very high blood sugar. He was in what's called hyperosmolar non-ketotic hyperglycemia. We still gave him the treatment, and we suspected that the diabetes was secondary to durvalumab. We got him into the hospital, gave him fluids, insulin. He is on insulin infusion, and he is now on usual Lantus Novorapid and doing quite well. So with that, we knocked off the pancreatic endocrine functions of pancreas. You can also knock out exocrine function of pancreas and cause pancreatitis. And unfortunately, in my first year, we did lose one patient with pancreatitis. And that was entirely because the surgical team was not educated about it. The patient actually went under the surgeons, and surgeons said, oh, this man has got advanced disease and has now got pancreatitis. We will palliate this guy. And unfortunately, I came to find out about this only after he was palliated and he had passed away. But we did an education session and explained them what autoimmune pancreatitis is and that it's a pretty salvageable condition. It does all sorts of endocrinopathies. most common endocrinopathy that we see is thyroiditis. Normally, I mean, when I've got these patients, I'll have them to have their blood test every 3 to 4 weeks, depending on what their regimen for immunotherapy is, which includes TSH and free T4 and T3 as well. Most of the patients, I'll show you how they actually present. They will present with significantly low TSH. They'll have low TSH and pretty high free T4, where it's just like Hashimoto's thyroiditis. They'll dump everything that's in their system into in the reserves and dump it into the system. So the TSH actually goes, free T4 actually goes up, whereas the T3 TSH comes down quite significantly. And you reach a point of infection, and I keep monitoring them. And when their TSH starts rising or T4 starts falling, I'll introduce some replacement thyroxine. Majority of these patients, they do not require any cessation of treatment. And that's where I mean by what's a replaceable organ versus what's an irreplaceable organ. So all the endocrine organs, be it adrenals, be it pituitary, be it thyroid, be it pancreas, I consider them as replaceable organs. There's no disrespect to these organs, but this is something that we've got drugs to actually cope with. So I would generally continue with the treatment. There was a bit of delay here to pick it up, and that is what would happen if we don't treat. So you can see the TSH actually going up. Now, all these patients can get symptomatic with hypothyroidism. It's very similar with adrenalitis or hypophysitis. So these patients can become quite tired, and you might see that the cortisol has dropped. You got to just work out whether it's coming from the adrenals or it's coming from the pituitary on the basis of ACTH simulation and on the basis of other pituitary axis hormones, whether what site is involved in the axis. And depending on that, you will replace. Most of the time, these patients would end up getting replacement steroids in the form of hydrocort or prednisolone to what their physiological replacement dose would be, working out with the electrolytes and the blood pressure. I would always get these guys to have their bracelet made or something in their neck which says that they are steroid dependent, just like you've got patients who have got Addison's disease. That's hypophysitis. One of the other common things that we see in the clinic is, I'll give you an example here. So Mr. AK, he was a 65-year-old gentleman who had recurrent skin cancer on head and neck, underwent partial penectomy in 2018, adjuvant wide radiation, then developed relapse in 2020. Also has a history of cutaneous SLE, but which was quite dormant. He had 3 cycles of neoadjuvant chemotherapy with cisplatin and capecitabine, had a decent response, but unfortunately post-surgery had wound dehiscence and could not get adjuvant radiation because of concerns of wound healing. At this point of time, we deliberated quite a lot because he had really, really high chance of relapse, and he had actually, forget about high chance of relapse, he had actually already started developing nodules around the resection site. So we started him on access program with Immunotherapy. He had few cycles, I think about 6 or 7 cycles of Immunotherapy, which was given every 3 weeks, and came up with this lot of rash. You can see he required a lot of bed dressings. We unfortunately had to abandon the systemic treatment, had to get his usual dermatologist involved, use bed dressings, steroid creams, oral steroids as well. So there's a spectrum of just a usual rash to patients who have had TENS-like syndrome and had to be admitted to Burns unit in Concord. That's the extent to which you can actually have derm or mucosal involvement. Just to give a feel of what various things can actually happen, So you can get mobile phenomena. That's the most common rash. I've got so many patients who have got vitiligo-like depigmentation. With vitiligo-like depigmentation, you really don't have to do much except for just monitoring them and just reassuring them that it's a good thing that it has happened. That basically means that the immunotherapy is possibly working. Patients who are already predisposed to dermatitis can get Lyconautic dermatitis. Again, steroids is the way to go. Very occasionally, you can get bullous pemphigoid. I would generally involve one of the dermatologists to help me out in what needs to be done in those cases. Now, this is not the end all of all the toxicities. If you actually go to the references that I've given, there is almost like another book that you can actually write. As I said, any organ system, be it bone marrow, be it kidneys, be it any organ can get inflamed, and there are slight variation in which you will manage most of these cancers, but majority of the time, steroids are the way to go. And you always have to still remember that with steroids, there is always this concern about risk of losing the control of cancer. Because as I had just shown you in the initial slide, the yin-yang, if you immunosuppress, the chances that you might aid in the cancer evading the immunosurveillance goes up quite high. Majority of the times, if you see that the patients have responded quite well initially and then developed them, and you have to stop them for stop the treatment for the toxicity, most of the patients will have continued good response to the treatment in the absence of treatment. There are, as I said, few cases where you have to bite the bullet and retry if you can. So if you've got any burning questions, I'm happy to answer them.
Thank you, Raj, for that very informative presentation, and really great to see the images as well that accompany all of those adverse reactions. I've got a couple of questions,
Yes.
and hopefully people will start putting things in the chat or put up their hands as well. One is just around the logistics. So, I mean, in my mind, I've gone, okay, I better pay closer attention to what treatments have been utilised during a patient's treatment course for their cancer, and if it includes a MAB, have a significant level of suspicion for whatever they're presenting with in the upcoming year, really. But say, we did have a suspicion that it may be an adverse reaction. From a logistical perspective, do we ring up your unit and say, got concerns, can we get the patient in to be seen today? What's the best course of action?
Yeah, so normally, Dr. Shua, we've got CNCs here. We've got 2 CNCs or 3 CNCs actually. Normally, so when we give the education, so I mean, I go through the first chart with those patients, with all my patients, and I actually instill the fear of God in them that if they don't report for at least 3 or 4 things like colitis, shortness of breath, or extreme fatigue, that they can die because of that. And that is actually true. Rest of the things I say that I'll actually manage them. So normally, if you educate the patients well, they will report it to us pretty quickly. But if you have got any concern, I'm more than happy to be called, regardless of whether it's my patient or not. If they're on immunotherapy, I'm more than happy to answer. I'm here 4 days a week, even 5 days a week during the daytime. If they want to come and see us, we've got a couple of fellows. Hopefully from next year, we'll have a full-time oncology fellow as well. We've got coverage for whole 5 weeks anyways. We've got an advanced trainee for first Monday and Tuesday, and we've got a resident doctor for Wednesday, Thursday, and Friday. So there would be someone who would be there to see. So even if you don't have to even ring us, you can just ask them to actually come during the business hours and just present to the reception and say that I need to see the doctor or one of the nurses or one of the CNCs, and we'll see them.
Fantastic. That's really helpful. Thanks.
And
the other
that just goes
question
out. And as I said, I'm very happy to be called as well.
Yeah, tell us about. The other question I had is, these MABs are also utilised in non-cancer conditions with a whole range of autoimmune type conditions. Would they have a similar side effect profile, or are the dosages used different?
Yeah, so Dr. Shua, so in autoimmune conditions, autoimmune conditions are generally due to hyperactive immune system. And with immunotherapy, we are making the immune system hyperactive. So we generally don't use these drugs in non-oncological conditions where the immune system is. So it is one of the relative contraindication if someone has actually got autoimmune conditions for us to actually use it. We still use it, but there is a very careful risk and benefit analysis that is done. In fact, all the trials have got autoimmune conditions, especially pneumonitis. With it could be radiation pneumonitis, it could be any evidence of pneumonitis at any point of their life. Those patients are actually not included in the trial. So we have actually used immunotherapy in a lot of these patients outside of clinical trials, and there is a lot of data. Anecdotally, though, the level of evidence is not that great, but you can safely use it with very, very careful observation. In fact, you can actually even use these patients in patients who have already had transplants. So transplanted patients who are immunosuppressed, like renal transplant, immunosuppressed, you can use it. There is always this dilemma of whether the graft is actually going to fail or not. And you always have to have this discussion with their transplant physician and the patient, explaining them that that can happen. And if they agree to it, like, again, the concept of replaceable organ versus non-replaceable organ. So if someone has had a heart transplant, you'll be very, very, very cautious. If someone has had a liver transplant, you'll be extremely cautious. But if someone has got renal transplant, where they can actually go on dialysis, if they still have the fistula in place, you can have a chat and use it. In fact, we had a patient under us who unfortunately passed away last year, who had a renal transplant, was on immunosuppression that I shared with Dr. McClintock, and we actually used immunotherapy in that lady, carefully monitoring what the graft functions were. So she lived for about 1.5 years and had treatment, ultimately died of disease progression and not because of graft failure.
Thank you. Does anyone else have any questions to ask? Feel free to raise your hand with the reactions box or type your question into the chat. Otherwise, we might move on to Kath's presentation. Thank you, Kath.
Thank you.
Thank you. Thank you for having me tonight. So my presentation is really just a brief overview and a little bit of a virtual tour of the Department of Radiation Oncology at the Western Cancer Centre in Dubbo. Sorry, I'll just get slides to progress. So this is just an aerial view of the outside of the front of the Western Cancer Centre, if you haven't been up there yet. And this is a big majority of our team that we have working up there. So in the radiation therapy unit, we've brought a lot of people to Dubbo and the region who have come from the profession and specialty of radiation oncology that hasn't been here before. So it's been great for the hospital and the community, but we've got a wonderful new centre to work in and brought a lot of expertise to the site. So in the centre itself, this is a similar picture to what Raj showed down in the corner here, and the front view of the hospital or the cancer centre. It is on the western side of the Dubbo Hospital, and on the ground floor we have radiation oncology, which includes external beam radiotherapy, a superficial radiation therapy unit and a PET scanner. And on the first floor, we have cancer therapies, which is chemotherapy, immunotherapy, hematology. There's a compounding pharmacy and a wellness centre. So Raj works upstairs and I'm on the ground floor. So on the ground floor, we have, for our external beam radiotherapy, we're a single LINAC centre. So we have one true beam linear accelerator. And this is a picture of the one we actually have in Dubbo. And it is the bells and whistles as far as external beam radiotherapy goes, which is really exciting for myself and all the team that work there, because when they started building small regional radiotherapy centres, probably about 15 to 20 years ago now, they started some research into were these centres viable. They would put pretty much the basics into the centres, and they weren't getting some of the imaging services and the additional things that the larger metropolitan centres have. That's not the case anymore, and it's definitely not the case here in Dubbo. So it's exciting for us to be able to share with all of you, as the primary care physicians looking after most of the patients that we see, that when they do come up to see us, they are getting the same treatment that they would get if they were in New York, London, Sydney, Melbourne, any large centre. It's just that we only have the one linear accelerator. With some of the larger centres, where I worked in Perth prior to coming over back to New South Wales, we had 7 linear accelerators. So same service, just on a smaller scale. So if you haven't been inside a radiotherapy bunker before or seen radiotherapy, please know that you're all very welcome to come up. I would be absolutely honoured to take any of you or a group of you on a tour through the centre so you can see what patients experience when they're undergoing radiotherapy. So this is the bunker where we house the linear accelerator. It's the patients are on these very flat, hard treatment couches, and they're raised high into the air where we know the isocenter or the 100% of the dose is delivered for the patient. And the head of the linear accelerator that you can see here on the left, it rotates around the patient at 360 degrees. We have, when I say we've got the bells and whistles, so things like for our breast patients, both left and right-sided breasts, we're doing deep inspiration breath hold, or DBIH, and this is the mounted gating system on the roof here. We place a small marker on the patient's abdomen, and we trace their breathing cycle with this camera that's mounted on the roof. We have an iPad type system that's mounted above the patient's head, and we coach the patients to be able to take a deep breath in, and that's when we actually deliver the high dose radiation. And when they've taken that deep breath in, it lifts the breast away from the heart and lung that lies underneath. So for breast patients in the past, the radiotherapy is very effective at managing and controlling the cancers. However, it does give pneumonitis and pericarditis as a late toxicity. We've been able to reduce that significantly since we've introduced the DBIH treatment, and that is something that we do here in Dubbo. We're probably ahead of a lot of centres, even in metropolitan areas, who aren't doing it on right-sided breasts. They're purely saving that for left-sided breast patients, but we have the capacity to be able to do it for all of our patients. So the PET scanner, I'm sure you've all heard about, and most of the community, both medical and the general public, are excited about the PET scanner. It became clinically operational in March of this year. It is only a part-time service at the moment, so it operates Mondays and Tuesdays. We are expanding that on demand. So just in the last 24 hours, we've had 8 referrals for patients that need a PET scan within the next 7 days. Because the service only operates on a Monday and Tuesday, next week we will actually scan on Wednesday to accommodate those additional referrals that came through. So at the moment, the plan to expand the service is all based around funding and allocation of funds to increase the staffing load. The equipment is there, the capacity is there, but it's around funding staffing. So as referrals keep coming through, and we do encourage everyone to keep referring to us and not referring through to metropolitan centres, because that's how we will be allowed to expand that service to become a full-time service, which was the original plan. We're hoping to get some great research and collaboration going, because it is one of the few PET scanners that is built inside a radiation therapy department. My understanding is there's only 3 in Australia. One of those is at the Peter MacCallum Cancer Institute in Melbourne, and we are the only regional centre in Australia that has PET scanning with radiotherapy. The FTG is made in the cyclotron down at Royal Prince Alfred Hospital in Sydney, and it travels by road out to Dubbo on every Monday and Tuesday morning. FTG has a half-life of 109 minutes, so that's a significant logistical challenge for us at the moment, and we are looking at other ways to work around that as we expand that service. So it does mean at the moment they can't start cannulating and injecting till around midday on a Monday and Tuesday. And the last couple of months, they're up to now scanning about 7 patients a day or 14 patients a week. You can see here on the scanner, so it does have a smaller bore. If patients are claustrophobic, it can create a few issues. We don't tend to find so we're using this very same scanner as a CT for radiotherapy planning purposes. You can see on the bed here, this is actually the breast board that we lay the patients on who are having their breast radiotherapy. They've got a knee fixed pillow, the creamy coloured shape here that goes under their knees for comfort. Everything is indexed, and the goal with radiotherapy is that we can reproduce the exact same treatment position every day. So our breast patients are having 15 treatments. We are hyperfractionating most of our patients, which is a fantastic benefit to regional centres where we can give higher doses in less treatments. So the breast ladies are having 15 treatments. You can see here is the iPad that goes above their head to coach them through that respiratory gating. And down the bottom, this image is just another angle of the same scanner. The big arc that goes across the scanner is a laser bridge. So with radiotherapy treatment, you possibly have had patients that have had radiotherapy before and they have a small tattoo. Again, we've got the latest technology with that. So the tattooing system that we're putting on patients, because a lot of the research says that patients do find that quite distressing to have a permanent mark or several permanent marks on their body to always remind them of their cancer journey, which sometimes they like to put behind them. So we have a tattooing system that the tattoos actually fade over time. So after 2 years, that tattoo will slowly fade away. We do have our imaging records now. If the patient was to ever to come back in the future, we don't really need those tattoos long term to actually align where we've treated before anymore. We also have a superficial or orthovoltage treatment unit. This is it when it was being commissioned at the end of last year. So it's just a very small, very basic X-ray tube, the same as what you would see in a lot of vet clinics or similar to what you have at dentists and different centres. We've commissioned this to treat 100 and 150 kV X-rays. So that'll treat to a depth of 7 millimetres. So most of the patients on this unit are SCCs, BCCs, melanomas. We've recently just done our first non-malignant patient who had keloid scars on both ears, a young chap in his 40s. He came back only today as a follow-up appointment and has had great success with that treatment. We've had a couple of Merkel cell carcinomas come through as well. And it is a busy unit because, as you can imagine, out in Western New South Wales, we do have quite a lot of skin patients coming through, and most of them are being referred by the GP network. So that pathway has been established and seems to be working well. But if anyone has questions around that, more than happy to take them. So this is our radiotherapy team. At the moment, we have an FTE allowance of 12 radiation therapists. We've just started our 9th radiation therapist with us only last week. We have 3 medical physicists. We've got a great radiation oncology nursing team, which we have established and used some of the expertise of some of the oncology nurses that were already in the Dubbo Hospital. We've got 2 nuclear medicine technicians and they run the PET scanner. The senior one of those techs has actually come from RPA, which Raj mentioned in his presentation is the busiest PET scanner in Australia. So she's extremely experienced. It has been really wonderful to bring a lot of people who grew up in the region back to the region. So our nuclear med tech grew up in Canamble on a farming property and has been gone for a long time and has now come full circle to come back to deliver healthcare in the region again. got a lot of admin staff and support who some of your own staff might work with referral pathways. We have an allied health program, so we have social work, dietitian, speech therapist and Aboriginal health workers all within the cancer centre. And most importantly, and I think the big message to make sure you're all well aware of, is we are supported by 9 subspecialist VMO radiation oncologists, and they travel in and out of Sydney. There's an awful lot of evidence to show how the subspecialist model in radiation oncology gives the best treatment outcomes. The team that we have are all based at Royal North Shore Hospital, and some of them do work in private practice as well. The model works for us because they're extremely progressive and innovative. So it allows all of our team to be doing the latest evidence-based practice, hyperfractionated treatment, which is great benefit to regional and rural patients. When patients are elderly or from a nursing home, we've had recently patients in their 80s from Cowra and Cobar and places, and we can do hyperfractionated breast radiotherapy in 5 fractions as opposed to not that long ago, and there are still some centres in Australia who would be delivering 25 fractions. So it's the difference between 1 week of treatment or 5 weeks of treatment, and getting really optimal outcomes for those patients. So having this subspecialist team is what is making our centre really unique and amazing for both the staff and the patients. So this is a list of those subspecialists. So if you have a particular patient demographic who you see regularly or you need advice, this is the team that you would refer to. So our medical director for the Western New South Wales LHD is Professor Thomas Eade. So Thomas does go to Orange once a fortnight, and we have, some of you may have in the past sent your patients to Orange for radiotherapy. We are running as a district service. So we have our own group of doctors who are coming in and out from Royal North Shore to Dubbo Hospital to the Western Cancer Centre each week. Generally, one of them is on site Tuesday, Wednesday and Thursday, and they usually come once a fortnight. So they work in craft groups. So DJ and Sarah do lung, palliative care, head and neck, CNS and skin, and they come alternate weeks. So for them, the burden of coming out here once a fortnight is absolutely fine with their current workload in Sydney as well. Our GU-GI group is Patrick Horsley, Jeff Ruby, Andrew Kneebone and Thomas Eade. And then Susan Carroll does all of our breast work. And then Michael Back, who you may have heard of, he's got a great international reputation with neurological work and stereotactic radiotherapy. And they can all be referred to from wherever you're practicing. And most of our patients do come through surgeons or medical oncology immunotherapy pathways. However, we really want to get the message out so that all the primary care physicians are aware that we are open and what we can offer. So our clinical services, as I mentioned, is external beam radiotherapy, the hyperfractionated radiation therapy, and all of our patients are treated with what we call VMAT, volumetric modulated arc therapy. And this is much better for the patient than static radiotherapy, where the linear accelerator delivers a dose staying static in a still position and moves to the next field and delivers another dose. VMAT is very conformal, so it allows us to have very small margins around the tumour. So most of our patients we're working with around a 3 to 5 millimetre margin, and it's very tight and conformal to that tumour, which reduces toxicity and allows us to go to higher doses because we've got those very tight conformal margins around the tumour. We are doing SBRT, which is stereotactic body radiotherapy for lung, brain and spine. Superficial, as I've mentioned, and the PET scanning, which at the moment is just FDG scans. In this financial year that has just begun, we have got a case in to get a gallium generator so we can start doing PSMA scans for prostate patients, and we hope that will be something that we'll see in this financial year. This is just an image of us showing, I guess, how we are doing things remotely. So the concept with radiotherapy is we have our team of radiation therapists like myself who deliver the treatment. This is a photo of us. So when we first opened, we treated our first patient in October last year. We've got this new TrueBeam linear accelerator, and myself and the team have come from all over Australia from different backgrounds and different centres. So some people have worked with different equipment. We weren't allowed to have, normally when you get a new linear accelerator, the standard is that you would fly your team to Las Vegas. They have a full clinical training centre there with a linear accelerator, and they deliver the training on site with the training at the training centre. Because of COVID, there was no overseas travel, so the concept was to have the trainers fly into our clinical site. And then not long before, probably about 8 weeks before we were supposed to start training, COVID actually locked down all of New South Wales and people weren't going anywhere. So this is an image of us with our trainer who was based in Adelaide. We had our webcam and we were able to show him everything as we did it, and we got really effective training. And it really set the centre up for similar to what tonight is, where we've all got very used to doing things online. It gave our staff and team the confidence to be able to do a lot of remote treatment delivery. So this is an example of that remote treatment delivery. This was only a week ago. We had a patient from Cobar who you can see this spinal lesion here. So this is our Dr. JMR DJ, we call him. He was in his office at Royal North Shore Hospital at the time. We delivered 30 Gray to this lady's spine in 3 fractions, or 24 Gray, sorry, in 3 fractions, in what we call SBRT treatment. So the goal with this is we've taken our initial CT in the PET CT room that you saw previously. We do the planning. So from Sydney, DJ's able to volume on in the red here what he wants to treat and what dose he wants to deliver to that area. On the treatment day, so we've had a couple of patients from Cobar, and some of them have been flown in by the Royal Flying Doctors, directly brought to the department. They stay for 2 or 3 nights and receive their treatment, and then they're taken back to Cobar. So the impact on the patient is really reduced. They're away from home for a lot less time because we have the centre now here in Dubbo, but we're delivering the same world-class treatment that that patient would get if they'd previously gone to Sydney or anywhere in the world, really, that has a world-class evidence-based radiotherapy centre. We then take the linear accelerator I showed you before in the images can do a cone beam CT. So we take that CT once we've got the patient set up ready for treatment. And in these images, what we're doing is matching the cone beam CT, which is in the moment live with the patient on the bed, with the previous planning images that we've taken. Our doctors, this is just on FaceTime. You can see here with my phone. So he can see on his screen in Sydney the image that we're trying to match. We will do the match and he will talk us through what he wants and what he likes and doesn't like. We've built here, this is our team with our physics, radiation oncology physicists and our radiation therapists delivering the treatment. We've been able to build that confidence in each other's services. So when we first started doing these really advanced techniques, we would only do it on the days when we had the doctor on site who was looking after that patient. We've now got that confidence amongst our team, and DJ feels the same way, where he's happy for us to deliver that treatment, and he watches us from Sydney through my phone to his computer screen. He's happy with what he can see. He knows the treatment's delivered. The safety mechanisms and QA around the SABRE patients is that we will do a cone beam CT before we treat. These do have high doses, so it modulates and takes a lot of monitor units and time to deliver the treatment. It's about a 3 or 4 minute treatment. So we stop partway through the treatment, and that is a long time for a patient to be staying still and receiving the radiotherapy. We'll take another cone beam partway through. And we have an allowance with this patient. The moves to adjust for any movement in her were less than 1 millimetre. And then we take a post-treatment scan just for our own validation to know that what we delivered was still in the same position at the end of the treatment. And to date, we've been really, really happy with the success rates of these patients and how accurate our treatment delivery is. So if you're looking to refer to patients to radiotherapy, it could be for radiotherapy treatment, for external beam radiotherapy, for a PET scan, for superficial skin radiotherapy. The best way to do that is through email. We do encourage you, it is an extremely long email address. So if you would like, I think Erica is going to send these slides out afterwards so your staff and teams can keep this on file. We do also have fax. Email's the easiest way for us, but we accept fax if that's easier for you. And you're welcome to call us if you've got any questions or we can help in any way. Our admin team who direct those calls are really used to, they've set the service up from the start and they're quite used to any questions that come through and guiding and triaging patients as things come in. So we encourage anyone to just contact us if you're not sure about something. So what's next for this cancer centre in Dubbo? Radiotherapy is a really progressive field, and so nothing really stays stagnant. There's always some new technology. I often explain to patients and carers that radiotherapy is a little bit like your phone or your car. What you might have had 5 or 10 years ago works and does the job, but there's a new model coming out all the time. Because we're image-based, the technology around what we can see and how we can see that and how we can control things remotely is always changing. The biggest change for us is the automation of things. So using big data, we're starting to collect data sets of treatments now and build our own rapid plan models so that we're able to cut down the planning time by hours and hours and put more of our staff time into research because we're automating a lot of the planning process, which was quite laborious in the past for the radiation therapists. So as I mentioned, the PSMA scanning is something we propose that will hopefully happen in the next 6 to 12 months. We've started a lot of research. We've just implemented what's called seamless radiotherapy for palliative patients. So we're using that for thoracic spines and lumbar spine patients. And that is we're planning the radiotherapy treatment from the patient's diagnostic scan. So the normal pathway is the patient would be consulted with the radiation oncologist, then they would come in for a simulation CT for us to build that digital picture of the patient so we can plan where the radiation will go and, more importantly, where the radiation won't go. So we're protecting those critical normal tissues that we don't want to get radiation. And then they would come back for their treatment, which could be anything from 1 to 30 fractions of treatment. With the seamless radiotherapy which we're using for palliative cases, we're eliminating all of the steps until the treatment. So we're consulting the patients via phone and video conference a lot of the time. Sometimes they are coming in if they are local and the doctor's on site. We're using the diagnostic CT, and that can be any diagnostic CT that's taken in the past 3 months. And we're using that to plan the radiotherapy treatment off. So it's for patients, particularly if they live as far away as Cobar or Lightning Ridge. We've had patients from Broken Hill. We're taking out that step where they need to come in and have a scan and then wait for us to do our calculations and all of our checks to start their treatment. And that was a Royal North Shore research project, which they're on over 800 patients on now. And we've been able to do some translational research and implement that in a regional centre and now look at the patient outcomes and demonstrating that patients in regional centres are getting the same outcomes as patients in metropolitan centres, but even greater benefit because our patients do travel so far still to come for treatment. And most importantly to all of us is we're trying to develop supportive professional connections within the Western New South Wales LHD. And these are referral networks and pathways with people like yourselves, with our specialists and with community health. So a lot of the time, the survivorship plans for cancer patients are really important. And we want to make sure that we can go back to being able to send those patients back into the GP network to get follow-up appointments. Can you see? Dropped off.
We've lost your sound, Cass.
Okay, let me see.
Oh, there we go. You're back.
And can you see my screen still?
We've got the Q&A session slide showing.
Okay, I'll just, reshare that. I don't know where it dropped off to. My apologies. So I've just got a couple of little slides that would just... So these are just a couple of the, we've had a lot of publicity, but yet there's still a lot of people I know, particularly for so many GPs, you're also fatigued and overworked and busy, that we do still hear of patients being referred to Sydney or different networks that aren't aware that we're open or what we do and what we offer. So that's really the concept of trying to get this message out. These are just some photos of some of the great team that you possibly already know in Dubbo, and then we've had federal politicians, Dominic Perrottet, come through with his state political team. We've had some great articles in the paper and through different social media outlets and different media to promote the centre. And it was fantastic. At first, we are still a little bit thin on the ground with staffing, and we were up to capacity with patients. So originally it was a 5-year plan for the Linear Accelerator to become working at full capacity, and it did take 5 weeks. And I'm sure that's a surprise to many of you, because you do work in the region and realise that you build it and they will come. The demand was always there, but it was very hard to capture the data on how many patients were travelling away, or more importantly, how many patients weren't being treated because the service wasn't available. So we are fully booked pretty much all of the time. We have a great triaging system, so we work through on a urgent plan and treat the next day, or start within 7, 14 or 21 days with all of our patients. So from that referral time to when they're consulted is usually within a week. And then they can start treatment usually within, well, a day to a week after that when it's urgent and necessary. Again, this is just that final slide with our contact details, and this has my email as well on it. I welcome any of you to contact me if you'd like to come up and have a look through the centre. If you've got patients that are on with us and you would like to just have a better understanding of what they're going through because you're following them up, by all means, contact us at any stage, and we'll make sure that you've got all of that information. And thank you. I'm happy to take questions if anyone has any.
Thank you so very much, Cass. We do have a question in the chat. I'd love some information about referral pathways, please. Perhaps an email document detailing this.
Absolutely. We'll. I'm not sure the best way to get that information out. We did try when we first opened to send all of that information out, but I am aware that there are a lot of people that haven't got it. So patients can be referred from their GP. We get a lot of skin patients from GPs, but generally, for example, our breast patients or our prostate patients, the quantity of our work would go through NDTs and have surgery, or they might go for immunotherapy or chemotherapy first. So we do tend to get most of our patients referred through that pathway of having some sort of adjuvant treatment. But by all means, any of you can refer to us. So if you have a patient you're not sure what to do, please contact us. You can send a referral, and our subspecialist would be happy to consult anybody at any point.
Fantastic, thank you. I remember sitting in a little room back in the Division of General Practice days, having that fight, trying to advocate for Dubbo to get a cancer centre, and unfortunately Orange won out at that point in time. So it's really lovely to see all of this come together so wonderfully. And we're so incredibly privileged to have a fantastic group of doctors, nurses, allied health, the radiation therapists, everybody, to be available for our patients. It's certainly been a long journey, and we're certainly seeing it come through for our patients who are no longer having to travel huge distances to get the care, and are in fact much more likely to say yes to getting treatment done in a timely manner. It's amazing. So thank you.
And we hear it every day with patients saying how great is it I can come here, or they may have even had some treatment in Orange and now they're able to come closer to home. And I guess just on that, what I didn't have in there is we do treat absolutely everything apart from pediatrics. We have treated a 17-year-old boy, and we are those late teens. It's something that we're capable of doing. It's just generally that they tend to go down to the Children's Hospital and stay under the care of their radiation therapist there. And in saying that, the Westmead PET scanner is down now till November. So only this week we've just been asked if we can take the paediatric patients that would normally be scanned there to have their surveillance scans with us. So if they're not under active treatment, yes, they can come and have a PET scan here, and that can be reported on by the Westmead physicians, and they can go back down there for their follow-up appointments. And as I think a lot of these things happen by the scanner is down at Westmead, they're going to send all their patients to Prince of Wales, but they've only asked this week if it's a possibility to have them scan here. So as far as equipment and staff expertise, we do have it all. We've got exactly what any metropolitan centre would have. It's just often about which specialist they're under and whether they want that in one comprehensive centre, or they're happy for them to have treatment here and then go back down to Sydney for surgeons or someone else that they might be seeing.
Sorry for that. I'll just make note that Erica had offered in the chat that the PHN could explore a GP tour of the new cancer centre in Dubbo. So just put that out there for everybody. And perhaps Erica, if you circulate that question around to the wider GP population, I'm sure there'll be a few takers. Do we have any other questions from the group? If not, I'd like to take the opportunity to thank both Raj and Kath for your really, really interesting and informative presentations tonight. We will, I'll just put a reminder out there for people to either scan the QR code that's on your screen at the moment, or else use the QR code that was emailed out yesterday. And that's useful then to for the PHN to do its reporting, but also, of course, allows you your CPD points to be earned. Thank you very much, everybody.
Just one more thing before you close, Dr. Chua. Can I just inform everybody that we, in all the likely probability, will be starting our first clinical trial in November this year.
Sorry, what will that be on?
So that would be, Dr. Chua, that would be patients with non-small cell lung cancers who, with their biopsy, have got a tumor proportion score of PD-L1 of greater than 50%. So they would be randomized to either the standard of care pembrolizumab versus the experimental arm of pembrolizumab along with sacituzumab govitecan, and follow them up for 2 years and beyond. That would be really good.
Amazing.
Yeah,
So exciting.
we are expecting that we will get a few more trials, and that would be such a good parity to get regional patients getting on the clinical trials and not having to travel to Sydney for them.
How far we've come in this period of time. Fantastic to see. Thank you very much again to our presenters, and thank you to the group for coming in. And Erica's gone, try this one, a different QR code. That will be left on the screen for a little while. And I'd like to bid everyone good night. Stay well, stay safe.